Mute. Mute. So now we are going to have our 9th lecture, and as the topic is visible here and also shared with you all, the topic is health expenditure and universal health coverage, recent initiatives of Government of India. So this topic is very important, very crucial, and very relevant also. We have huge database on this topic, and along with that, we have great conceptual issues also. So this lecture is divided in 4 sections. We'll talk about 4 different issues here. First thing is health expenditure in India. Second, why do we need to talk about universal health coverage? Third one is the initiatives taken under the universal health coverage in India. And the fourth one is an assessment of the existing models of universal health coverage in India. You may remember we had a discussion on this topic when we were talking about the health disparities and inequalities also. So now I'm coming to the section 1, but here these are some of the books authored by me or edited by me. And Sociology of Health, this is a very relevant book for all participants if they are interested in understanding this Sociology of Health. Let us come directly. Health expenditure in India, the key health financing indicators. So what is expenditure basically? We all are aware of the term expenditure. When we spend money on certain items, then this is known as expenditure. Income, when we get money for something, that is income. And when we spend that money, that is expenditure. So every state or country basically has some source of income, and then there is a kind of budget where the state is planning to spend the amount or the income. We all know that there is a gross domestic product, per capita income, gross national income. We are aware of these concepts. So India has its own gross national income, and all those parameters we are aware of. Now we are talking about what is the percentage of the income of the state which is being spent on health or health related issues. Here it is very important to know or understand that the developed countries spend 5 to 7% of their GDP in health related needs, right? Because spending a huge amount on health related issues has become a good indicator of the state of development of that particular country, right? That means if a state or a country is spending higher proportion of its income on health needs, then that is considered as a very people-oriented state who is taking care of the health needs of the population, because we all know that without spending money, no facility could be created or generated. So we will start with that kind of understanding. Now, these are the figures which have been provided by Government of India. The source of this table is Health and Family Welfare Statistics in India 2019-20, and that is accessed from the National Health Accounts data, right? In the second lecture today, we will talk about the sources of data in India, and there we will talk about the different sources which are available in India for the government data. Of course, there are private data also, but for the government data, right? So these are authentic data taken from the government websites. Now, the total health expenditure as percent of GDP. So this is very important. because 100% of the GDP is allocated for different sectors. We all know that defense is one of the most important sector which needs a huge amount of spending. And then after that, there are several other sectors. Education is one important sector. Rural development is another important sector. Infrastructure is another important sector. Railway is important sector. All these sectors are there. So how much money the state, or that means the Union of India, is spending on health? The total health expenditure as percent of GDP as of now, as per the available figures of the national health accounts for the year 2016-17, was 3.8%. Now, if we look the figures of some previous years,
Excuse me, sir.
15-16, yes.
Good morning, sir. So this
Good morning.
is Shivani Patel from University of Allahabad.
Yes.
So I want to ask that what is the subheads, major subheads under the heading total health expenditure?
Please wait. Please wait. We will see. There are so many slides, right? Please wait. We have a specific tutorial class for discussing all these things. We have so many things to share, right?
Okay.
I provide you whatever data is available to the government records only, right?
Okay, thank you, sir.
Right. So this in the year 15-16, this was 3.8% again. 14-15, it was 3.9%. 13-14, it was 4%, and 2004 and 5, it was 4.2%. So what is visible here? One thing that we can understand over here is that over the decades, this allocation has slightly decreased. That is the total health expenditure. Now we move to the next figure, that is total health expenditure per capita. Right? Per capita, we all know when we divide the gross by the population, we get the per capita. Now, as per the current prices, now these are basically economics related terms, but current prices basically does include the inflation related things. So we have a base price and we have the current price concepts, right? So as per the current prices, we can see that in the year 2016-17, it was 4,381. And then the previous year, that is 15-16, it was 4,116. And then we can see that in 2004-5, it was 1,201. That means we are witnessing an interesting thing, that the per capita expenditure progressively has increased from 1,200 to 4,381 at the all India level. Then we come to the next figure, that is the total health expenditure per capita rupees at constant 2011-12 prices. Because the current prices does include the impact of inflation, so we have the constant prices 11-12. Now when we make a comparison, we see this, that in 2016-17 it was 3,500. In 15-16, it was 3,400, and in 2004-5, it was 2,066, right? So you compare the figures, 1,200 in the previous row and 2,066 in the current row, right? When you make prices comparable on the basis of the constant prices, then the figures basically appear very different. However, even here we can see that the total health expenditure per capita wise is increasing. This increasing trend is something that we take into consideration. Then we move to the next one, that is the current health expenditure as percent of the total health expenditure. The current health expenditure as percent of the total health expenditure, this is not something very important for us, but yes, it does talk about some kind of the longitudinal spread of the budget kind of thing. Now, what is important for us is actually the government expenditure and the private expenditure. Private expenditure in the sense that the personal kind of something which we identify as out of pocket expenditure, right? That means as an individual, if I'm going to avail of certain health facilities, then how much amount I'm spending from my own pocket. That is known as the out of pocket expenditure, because when there is an amount being spent at institutional level, then it is not necessary that the entire amount is being spent by the government. Part of the amount could be spent by the government and part of the amount could be spent by the individuals. So this expenditure at the individual level is known as the out of pocket expenditure, and primarily our core concern is related to this. The government health expenditure percent of the total health expenditure is 32.4%. And you can see that in 2004-05, this was 22.5%. So from 2004-05 to 2016-17, the proportion of the government's expenditure has increased. And similarly, you can see in the next row, out of pocket expenditure as percent of the total health expenditure is 58.7 for 2016-17, and it was 69.4 for 2004-05. That means the out of pocket expenditure has decreased gradually, and the government's expenditure has increased gradually over the years. This is something very important for all of us to understand, that what is happening in terms of finances in the domain of health. Then there is another important point. Point number 7, that is the social security expenditure on health as percent of the total health expenditure. Now, when you were asking that what is the basically internal composition of this, so we are not having a detailed information about the internal composition, but important categories are there. For example, the social security expenditure. We can see that the social security component has increased. Earlier it was, that means 2004-05, it was 4.2%, and as of now it is 7.3%, right? And then we come to the next important thing, that is the private health insurance expenditure. The private health insurance expenditure has increased significantly. In 2004-05, it was 1.6%, and as of 2016-17, after a decade or something more, 4.7%. Almost 3 times increased, right? So this is the core understanding about the total health expenditure. We have several other tables to talk about, and all those tables will give you an insight about the health expenditure issue. Then we will come to some of the very important and relevant points also. Basically, we will try to understand the universal health coverage, and this health coverage, to what extent that is actually successful in reimbursing the expenditure made by the individual. That is also a core concern, right? So we had a broader understanding of the health expenditure at the level of the government. We come to the next slide. The total health expenditure, then the government health expenditure, and out of pocket expenditure, major states. Because earlier we talked about India as a country, the union of states. Now we will talk about some of the states. Now this is very important. You have been hearing that in some of the states of India, the health indicators are much better. In some other states, the health indicators are not performing that well. So we need to know how much money or what percentage of the income the state governments are spending on health. Without knowing this, we cannot make a conclusion. We cannot reach to any conclusion. And along with that, we also need to understand that what proportion of the money is basically spent by individuals themselves. That is the out-of-pocket expenditure. And then what is the ratio between the government expenditure and out-of-pocket expenditure? So this is a very important slide in this context. Now we can see that in the Andhra Pradesh, the green, all these green bars are symbolizing the total health expenditure. The yellow ones are symbolizing the out-of-pocket expenditure, and the red one, the government health expenditure. So what the developed countries are having, they are having high government expenditure. And if there is a high government expenditure, then certainly the out-of-pocket expenditure will be low, right? I hope you understand this thing. If the government expenditure is high, then people will not be compelled to spend from their own pockets, right? So when the government expenditure is low, then people have no choice but to spend from their pocket. And when the government expenditure is high, then there is a possibility that the out-of-pocket expenditure could be low. But there is also a situation that the government expenditure and out-of-pocket expenditure both are high. So we will see these things. We'll take a few states. For example, Andhra Pradesh, because it starts with A alphabetically, we can see that the green, that is the total health expenditure, is definitely high because that is the total of both the expenditures. But out-of-pocket expenditure is very high, right? If you can see the graphs and make a comparison in your visualization, you can see that the government expenditure appears to be less than 1/3 of the out-of-pocket expenditure. In Bihar, the situation is even more critical. The government expenditure is much lesser, less than 20% of the out-of-pocket expenditure. Whereas in Gujarat, you can see that this yellow bar and red bar are very comparable, almost like 55%, 45%. That means the share of the government in the total health expenditure is very high, right? That is an indication of the development of a state, and that is an indication of the governance. Then we come to Karnataka. We can see that in Karnataka, the overall expenditure is high, higher than all the other states that we have discussed till now. And again, the gap between the government and the out-of-pocket is lesser. So far, we have seen that in Bihar, this gap is the highest. In Karnataka, this is lesser, not as less as in Gujarat, but in comparison to Bihar, the gap is lesser. And then we come to Kerala. Kerala is one of those states which is having very good health outcome, very good health indicators. And even here we can see that the ratio appears to be like 1:3. That means government expenditure is, if government expenditure is around 30%, then the out-of-pocket expenditure is 70%. That means if Kerala has ensured good health outcome, it is not just because of the state expenditure, but it is also because of the out-of-pocket expenditure. Right? That is very important and interesting. Then we come to Maharashtra, because that has a huge total health expenditure, right? And then we come to UP, Uttar Pradesh. Out of all these states, the highest health expenditure is in Uttar Pradesh, and we all know that the population of Uttar Pradesh is basically the largest. And what is important that the gap between the government expenditure and out-of-pocket expenditure is also very high. So the government expenditure is less than 20% of the total expenditure. That means the burden of this out-of-pocket expenditure is high in state like Uttar Pradesh, or for that matter, even in Bihar and Andhra Pradesh also, and other states that you can see. So if you understand the pattern of expenditure, especially in the context of the state and the out-of-pocket, you can understand what kind of impact it will create in the pockets of people, right? I hope you got this point very well. Then we come to a very important thing, breakup of source of finance of expenditure at household level. When we are talking about out-of-pocket expenditure, that means the expenditure made at the household level, right? What people spend at the level of their own household. So when somebody is spending money at the household level, then where from he or she is getting that money? If I am spending some amount, then what is the source of that amount for me? Now, this is very important. See, there is 3 components here. One is the household income or saving. The red one is the borrowing. And the blue one is the others. And below the table, I have mentioned this others. Others include sale of physical assets, contribution from friends and relatives, and other sources. That means sometimes people have to sell their assets. That means their house, their land, or whatever things they are having, right? And the red is symbolizing the borrowing. That is when you take some kind of loans from banks or the other agencies, right? So we all see that invariably the green bar is much longer. But what is worrying is this, that even the red bar and the blue bar is significantly visible. That means people are spending on health needs by borrowing money from others or taking loans or even selling the assets. Now that kind of impact is basically getting created. So when we talk about out-of-pocket expenditure, don't ever think that this out-of-pocket expenditure is met by the household income or savings. Even if it is coming from savings, often it happens that the entire saving, the saving of the lifetime is spent when somebody is becoming sick. That means the burden of health expenditure is huge at the level of the individuals and household. This is something that we need to understand. We have been talking about healthcare facilities, accessibility, availability, disease, all these things. But what kind of consequences it is creating to the economy of the households or individuals, that is actually problematic, right? I'm sure that this kind of breakdown of the expenditure would be very helpful for developing your own insights. Now, we come to a very interesting aspect. When we talked about the expenditure, let us try to see at a deeper level that where does the money go? When we spend the money, then where does it actually go? We look at the bills in a lump sum way. But here in this table, a very interesting information is shared. Breakup of average medical expenditure for hospitalization in public, private, and rural, urban. So we have the private hospitals and we have the government hospitals. We have the rural areas, we have the urban areas. In rural areas, we have public hospital as well as private hospitals. In urban areas, we have public hospital as well as private hospital. Now let us see how much we spend when we get hospitalized in a private hospital or a public hospital. First of all, this difference is huge. If you can approximate from this chart, you can see that in the rural areas, when somebody is getting hospitalized in a public hospital, that is a government hospital, the average expenditure is around 7,000, 7,500. And even in an urban area, when somebody is hospitalized in a public hospital, this is slightly more. So if it is 7,000, it is around 8,000, slightly more in urban areas. But when somebody gets hospitalized in a private hospital, then even in a rural area, the average expenditure is around 30,000. That means at least more than 4 times. So the expenditure incurred in a government hospital in a rural area is 4 times lesser than the expenditure incurred in a private hospital in a rural area. And then you come to the last bar, that is the private hospital in an urban area. And the figures are closer to 38 or 39,000. So 39,000, that means a government hospital in a urban area will incur you something around 8,000 rupees on an average, and a private hospital will cost you around 39 or 40,000 rupees on an average, 5 times more. And this is something that we see in our personal experiences also, right? But perhaps we were not aware of the things in a quantified way by making use of a government figure. And see the source here, Health and Family Welfare Statistics In India, 2019-20, Government of India 2020. So these are not the old figures, these are the recent figures, pre-COVID figures, right? So one thing is very clear, that the cost of healthcare in private hospitals is very high, right? So now we can have a larger pattern. The government is not spending much, and the larger burden of health expenditure is going to the individuals in the form of out-of-pocket expenditure. That is one side of the story. And the other side of the story is this, that when people get hospitalized in a government hospital, then the expenditure is much lesser, 4 or 5 times lesser. And when that person is going to a private hospital, then the expenditure is high, very high. And then we come to another important point, the breakup of these expenditures. See, the tallest bar here, right? That is private hospital in an urban area. Bed charges are there, diagnostic test charges are there, medicines are there, then doctors, surgeons fee is there, and then a package component is there. Now, when we can see that the bed charges are there, diagnostic tests are there, medicines are there, doctors or surgeons fees is there. So almost all the known expenditure are already there. But along with that, there is a huge package component, something that we do not know. And basically, this is the amount that the corporate hospitals or the private hospitals charge, that we are not aware of, because we have already paid the bed charges, the diagnostic test charges, the medicines, and the doctor's fee. So that is the premium that they collect, and you can understand it. It is not mentioned over here, but you can understand it, that is the profit that they are earning, right? So what has the reality is this, that the private hospitals have become a source of earning or a profit-making institution. Now we come to another important thing, something perhaps all of us are familiar, because when we are talking about health expenditure and when we need to talk about the universal health coverage, then we need to understand basically the breakup in terms of the various disease or problems that we face. In this table, we have mentioned some of the specific disease and then the average cost in a public hospital and in a private hospital, right? See, cancer, we talked about cancer, we had one full lecture, right? Now, the average cost of expenditure for treatment of cancer in a government or public hospital is around 22,520. And the average expenditure in a private hospital is 4 times more than that. That is 93,000. That means one person is getting admitted in a public hospital, is spending 22,000 on an average, and if the same person is going to a private hospital, he or she is spending more than 4 times. That is the difference between a public hospital and a private hospital. Then let us come to some other, say, infection, the last item. Infection is a minor kind of thing often. And if you go to a government hospital for seeking treatment of an infection, then the cost would be around 2,054. And the same thing, if you get hospitalized in a private hospital, then this is more than 7 times, that is 15,000. That means at a bottom level, the difference between the government hospital and the private hospital is huge, right? So I hope by now you got an idea about what kind of differences are existing when we seek treatment either at a government hospital or in a private hospital. So by now you have developed broader understanding about health expenditure patterns. I have just 2 small slides, because when you are talking about the government and private hospitals, then we do need to have an idea about what is the proportion of availability of the government hospitals or the private hospitals. So this pie chart is showing you that. You can see the government and public hospital in the rural areas, these are around 33%. If the government hospitals composition is 33%, Then all the rest basically come to the private hospitals, although there are different nomenclature suggested here. One is the charitable trust, NGO run hospital, then the private hospital, then the private doctor or private clinics, then the informal healthcare providers. So keeping aside the charitable or NGO run hospital, because these are the not-for-profit institution, all other come under the category of private hospital, where you have to pay money from your pocket, or if you have some kind of insurance card. So the point here is this, that in India, the rural level, we have 33% of the hospitals which are coming under the government, and the remaining, except the one run by the NGO or trust, that is 1%. That means almost 64% come under the private. So this indicates the spread between the government and the private. So what is clear till now? That there are 64% health facilities available in the private, and the cost of treatment in a private hospital is minimum 4 to 5 times more than the cost of treatment in the government hospital. And at the overall level, we have seen that the states are spending much lesser, and largely the expenditure is made by the people on their own, that is known as the out-of-pocket expenditure. So this is the expenditure pattern. I hope you got clarity on this. The same chart I presented in the urban context also, but you can see the difference. In the rural areas, there was presence of 33% government hospital. In urban areas, this is further decreased. This is only 26%. That means almost 74% or 73% are basically private. And this is also visible. In every urban space, you can see that there is plenty of private hospital, and the availability of government hospital is much lesser. Sometimes this is also explained as privatization of health expenditure, right? Because we can see that the presence of private hospitals is increasing. Rather, they are having almost 70% to 75% presence, and that is also largely considered as privatization of healthcare. So now we got an idea about the health expenditure part. And so we come to the next part of the lecture, that is health coverage or universal health coverage, right? So what is this universal health coverage, and how did this concept evolve, right? We need to have some kind of basic understanding about that also. So let me start. Across the world, more than 100 million people are pushed into poverty each year because of healthcare expenditure. This is an avoidable tragedy. So expenditure on healthcare is one of the major causes of impoverishment, causation of poverty. We all might be aware of the thing that almost every government is talking about poverty eradication or removal of poverty. But unfortunately, we are not in a position to address the problem. In India, several governments came on the promise of removing poverty, but unfortunately, that is not happening. Why that is not happening? Because the cost of health expenditure is increasing. And this in itself is one of the major causation of poverty. Perhaps you are not aware of this. And that is why we need the attention of the social scientists to the problem. When people ask that what do sociologists, or for that matter, the social science people do in the domain of healthcare, then we talk about these things. See, this is what is existing at the grassroots level. People are becoming poor because of this. Now, striving for the goals of universal accessibility and affordability of health and healthcare, World Health Organization proposed a model for health system financing. So keeping in mind this kind of catastrophic impact of health expenditure, WHO took initiatives to develop a health system which can address the problems related to health financing. An important development after the Millennium Development Goals at the global level to health policy and planning is the development of a new vision of universal health coverage for citizens at national level. So after the MDGs that we had at the turn of the millennium, that is the Millennium Development Goals, it became an important concern for the global agency to address to this problem. That how can we address, how can we protect people from the catastrophic impact of this high cost of care? The member states of the World Health Organization committed in 2005 to develop their health financing system so that all people have access to healthcare services and do not suffer financial hardship paying for them. So WHO initiated the discussion, and then the member states basically committed, including India, that they will develop a system, and that system is basically known as the Universal Health Coverage System. This goal was defined as universal coverage, sometimes called universal health coverage. So this is how this concept of universal health coverage basically developed on the initiative of the World Health Organization. Now, what is the scenario in India? The scenario in India basically we'll try to understand, and for that we need to understand the composition of a high-level expert group way back in 2010. As suggested by World Health Organization, the government of India constituted a high-level expert group in 2010 for suggesting the model of universal health coverage for India. It had 6 terms of reference. So when the government constituted a high-level expert group, then it provided them 6 terms of reference on the basis of which the group was supposed to give its recommendations. And those terms of references included financing, resource generation, ensuring access to essential drugs, vaccines, and medical technology, and allowing participation of private for-profit sector in delivery of healthcare in India. So see the last point. The government basically made it a point that there should be provisioning for for-profit sectors in delivery of healthcare. So when we are saying for-profit, that means we are differentiating them from not-for-profit. So the non-government organizations or trusts are generally identified as not-for-profit sector, and the private sector is generally identified as for-profit sector. They come to the field for earning profit, right? So under which terms and conditions this private or for-profit associate organizations could provide the services, that was also one of the terms of reference. And the committee members on their own basically included one more important factor there, that was the social determinants of health coverage, right? That was not initially proposed by the government, but the members included this term of reference. Now, the health level expert group made several recommendations. Some of the recommendations I have highlighted. One, that is public expenditure on health to at least 2.5% of GDP, right? It was stated that in India, the proportion of GDP that is spent on health needs is varying between 1% to 1.5%, right? The proportion of GDP on health expenditure is varying between 1% to 1.5%. Then this expert group recommended that it should be increased to 2.5% of GDP. And then it should also be increased up to 3% by 2022. So you need to remember this point, that it had recommended that this proportion of GDP to health should be increased to, up to 3%. And then ensure availability of free essential medicines, and then all government funded insurance schemes should over time be integrated with the universal health coverage system. There are different basically health insurance system existing. Sometimes these are basically run by the individuals on their own. Sometimes these are run by the state governments. There are different insurance systems. We'll talk about that in next few slides. These are some of the other important recommendations. I'll share the slides. If anybody interested in seeing the recommendations can go through these things. Because we want to discuss the actual health insurance model, right? So we have been talking about the problem, then we talked about the policies. Now we come to the actual part, the way the things are getting implemented, right? Now I've taken this data from an accompanying document of the National Health Policy 2017. See, what was happening that before the health policy of 2017, we used to have the health policies which included an assessment of the existing situation. That means if you are having a specific policy of the government, then that policy document in itself is including an assessment of the overall prevailing situation. But this time, the National Health Policy didn't make the assessment in that document, rather it published that document separately, right? And that document was named as Situation Analysis Backdrop to the National Health Policy 2017. So I've taken this information from that. So let us see what kind of situation was prevailing up to 2017. Publicly financed health insurance. Now, when you talk about basically universal health coverage, then there are different models operating. Some of these are basically identified as health insurance model. Now, what is this health insurance model? That at the individual level or community level or family level, some kind of health insurance will take place. And when somebody is becoming sick or basically getting hospitalized, then he or she can claim a kind of reimbursement. Now, this insurance may operate at different levels. Sometimes it can be a cash-free treatment. Sometimes it could be like you have to pay and then you can claim a reimburse. It will depend from state to state, and it will vary from program to program. So what program we are talking about now? We are talking about the publicly financed health insurance. A number of publicly financed health insurance schemes were introduced to improve access to hospitalization services and to protect households from high medical expenses. 8 states introduced health insurance program for covering tertiary care needs. Now, how many states? 8 states. And which part of the health expenditure? Basically, the tertiary care. Now, we are aware of the fact that there is a primary care, there's a secondary care, and a tertiary care, right? Primary care, which is operating at the household level or the community level. Sorry, excuse me. Thank you. However, many of these states like Andhra Pradesh, Karnataka, Tamil Nadu, Maharashtra moved to direct purchase of care through trusts, while reserving some services to be delivered only through public hospitals. Now, I just stated that the different models prevailed, right? So within this publicly financed health insurance, multiple models existed. It will not be technically possible for us to understand all these models individually. We can understand the core issues related to this. One important issue here is this, that this is publicly financed. That means that will run on the basis of the taxpayers' money, right? That the state will launch this. Now, some states are going directly to purchasing directly these health insurances from the health insurance provider companies. And some are purchasing this through certain trusts, which may include the not-for-profit kind of trust. So it will vary from state government to state government. You can find out what is happening in your state, right? Then the central government launched the Rashtriya Swasthya Bima Yojana, RSBY, in 2008. Now, this was a mega program in the direction of providing health coverage to people or health insurance to people. The name Rashtriya Swasthya Bima Yojana, that is National Health Insurance Plan or scheme, right? The population coverage under these various schemes expanded from almost 55 million in 2003-04 to about 370 million in 2014. Now, what is important here is this, that the number of beneficiary is increasing. Now, I would like to point out one important thing here is this, that this Rashtriya Swasthya Bima Yojana started in 2008. That means much before the recommendations made by the high-level expert group, right? That means we should not say that our governments have never taken care of these needs. The governments have taken care of. But the problem is basically related to the coverage, to what extent the people are getting, or what proportion of people are getting these benefits, or in which state the people are getting these benefits, right? Nearly 2/3, 180 million of this population were those in the below poverty line category. So I talked about this, that which component of the population, primarily it was the below poverty line category. That means people who were living in below poverty line, who do not have the affordability to take into consideration the health needs, right? So on the one side, we have the government hospitals, private hospitals, and on the other side, there are people who are living below poverty line, who are not in a position to meet the basic needs, the needs related to 2 square meals. So how can they spend the money on health needs? So for these people, basically the unprivileged or underprivileged people, there were schemes like Rashtriya Swasthya Bima Yojana. However, an evaluation was made, because we are talking about the health policy 2017. So before the launch of this policy, the government basically made a kind of evaluation, and it did find some kind of irregularity and irregularity kind of thing. It was not functioning very well. Evaluations show that schemes such as the Rashtriya Swasthya Bima Yojana have improved utilization of hospital services, especially in private sector and among the poorest 20% of household and SC/ST household. However, there was low awareness among the beneficiary about the entitlements and on how to use the Rashtriya Swasthya Bima Yojana card. So you might have seen some people having those RSBY cards. So although the provision was good, but people were not having some kind of awareness. And in our empirical experiences, we have seen that very often it happened that person went to a private hospital and then provided his health card, and even for a small disease, the hospital basically manipulated the things and provided a huge bill and got the entire amount available to that card basically used over there. In that situation, what happened that somebody became ill, got hospitalized, and his or her card got exhausted, and maybe after 3 months, 4 months, 6 months, that person became ill again, and that time there was no limit available to the card, and so he or she could not get that health facility. So that was the biggest problem. That is the biggest problem of this model, that no matter how much amount is available in your card, but if you are getting hospitalized, then there is a possibility that the entire amount may get exhausted there, and there is no guarantee that the person will not become sick again. If the person is becoming sick again, then there is no limit available. That means he or she will not be in a position to get any medical care, right? Another concern is related to denial of services by private hospital for many category of illness and oversupply of some services. We talked about one problem. Another problem was this, that basically the hospitals made some kind of irregular provisions for providing these services. Now we come to the National Health Policy 2017, shift in approach towards universal health coverage. So the 2017 health policy made a huge announcement related to universal health coverage. We all might be aware of that announcement because that was published out, and some of these components are visible also at the ground level. So I will not say that everything that was announced at that point of time has become a reality as of now. But yes, there are several components which became reality. Maybe some other announcements will become a reality in time to come. So this is the universal health coverage model that we are following in terms of policy as of now. Let us see what are the provisions related to it and to what extent these are getting implemented. We have come to the last part of this lecture. Now, assuring availability of free comprehensive primary health care service for all aspects of reproductive, maternal, child, and adolescent health, and for the most prevalent communicable, non-communicable, and occupational diseases in the population. The first claim that this policy is making is that the state should ensure availability of free comprehensive primary health care service. And it has further identified the specific areas like the reproductive health, maternal and child and adolescent health, and the communicable and non-communicable and occupational disease, right? That means it primarily covers all those needs which could be identified at the primary health care level, right? Then it advocates collaboration with the non-government sector on pro bono basis. This pro bono basis is a very technical term, and I've explained it here also. What is it? For delivery of healthcare services linked to a health card to enable every family to have access to a doctor of their choice from amongst those volunteering their services. That means there will be kind of health cards available, and there will be service providers. It may the providers may come from the government or the public, right? But it will be the choice of the health seeker to go to any of them on that pro bono basis. You can look at the modalities of that pro bono basis separately also if you are interested. Then ensuring improved access and affordability. Now, when you are talking about improved access, that means availability is there. In your neighborhood, there may be a very big hospital. But can you afford to go there? Can you go there? Do you have an access related to that? So most of the time, people coming from below poverty line or say a lower middle class or even up to the middle class do not have access because they do not have the affordability related to that, right? So how can we make affordable those services? There is something related to that also. Purchasing of services in healthcare deficit areas from private care providers. Now, this is interesting. Basically, when we talk about availability, then for a specific treatment, there may not be the availability of a government hospital in that particular area. So under those circumstances, the private healthcare providers can also provide the services even for those people who are getting benefited by the specific program, right? And achieving a significant reduction in out-of-pocket expenditure. So this point C is the most important point. The specific purpose is to reduce the burden of the out-of-pocket expenditure. See, all these modalities basically came into existence to address to the problem of catastrophic impact at the household level or at the individual level. And so this policy document also says that whatever universal health coverage model we are having, the ultimate goal is to reduce the burden of the out-of-pocket health expenditure. Then I would be interested in talking about the way the concept of health coverage has been broadened in India. WHO did talk about health coverage in terms of the economic aspects, but the National Health Policy of India in 2017 had broadened the domains of or the dimensions of this health coverage. Last time during COVID, we had seen lots of discussion on vaccines. Now, it would be interesting to know here that this policy does talk about basically improved immunization and vaccination, right? So under the term coverage of health services, there is a provision of universal immunization. We all are aware of the fact that the children are getting immunized and those facilities are provided by the government. But it is not remaining confined to children only. Rather, this policy says that universal immunization should be the priority of the government. Priority would be to further improve immunization coverage with quality and safety, improve vaccine security as per national vaccine policy, and introduction of newer vaccines based on epidemiological consideration. The focus will be to build upon the success of Mission Indradhanus and strengthen it. So there is a Mission Indradhanus. We'll talk about that very briefly in other slides also. So coverage in terms of population and services will expand gradually. Right. So what does this policy talk about? It talks about expanding the notion of universal health coverage so that it should not remain confined only to address the economic aspects or the reimbursement, but should also broaden the notion of immunization. And we all became a beneficiary of this initiative during the COVID time. Now we come to the Ayushman Bharat concept, right? This is again one of the very ambitious programs announced by the government of India. It does include some of the earlier existing policies and programs, but as of now, this is one of the largest programs. And as it was announced by the Prime Minister of the country also, that this is the most massive or mega program announced anywhere in the world, right? The whole purpose here is that nobody should be left behind in terms of health coverage. Ayushman Bharat is an attempt to move from sectoral and segmented approach of health service delivery to a comprehensive need-based healthcare service. This scheme aims to undertake path-breaking intervention to holistically address the healthcare system, covering prevention, promotion, and ambulatory care at the primary, secondary, and tertiary level. So you may remember when we talked about the health insurance program of 2008, primarily that was covering the specific sectors. But here, this Ayushman Bharat is saying that it will extend the services at all levels, that is the primary, secondary, and tertiary level. Then Ayushman Bharat adopts a continuum of care approach comprising of two interrelated components. So continuum of care, that means there should be a continuity in care, right? And what is this continuity in care? To understand that, we need to understand these two important components. What are these two important components? The health and wellness centers, HWCs, and the Pradhan Mantri Jan Arogya Yojana, PMJ, right? You might have heard the names of these two things, HWCs, health and wellness centers, and PMJ, that is Pradhan Mantri Jan Arogya Yojana. Now, what is this health and wellness center? Interesting to know. In February 2018, the government of India announced creation of 150,000 health and wellness centers by transforming the existing sub-centers and primary health centers. So now, under the health policies and programs of India, we had a structure of care. And under that structure of care, there was provision of sub-center, then primary health center, then the community center, and further other layers, right? So the sub-centers and primary health centers were operating at the bottom, right? For population up to 5,000 and population up to 25,000 categories, right? Those sub-centers had some kind of provisioning of medical staff, and the primary health centers had basically deployment of the medical personnel, right? So we already had that sub-centers and primary health centers. Now there is a creation of 150,000 health and wellness centers, converting those sub-centers and primary health centers, but in a new format, making them available in a new format. These centers are to deliver comprehensive primary health care, bringing health care closer to the homes of people, right? So that is the concept of health and wellness center. And the next one, that is the Pradhan Mantri Jan Arogya Yojana. Ayushman Bharat, PMJ, is the largest health assurance scheme. Now you mind the word assurance, it is not insurance, right? It is not insurance, it is assurance, that is assuring. Health assurance scheme in the world, which aims at providing a health cover of rupees 5 lakh per family per year for secondary and tertiary care, hospitalization. So the primary care will come under the health and wellness centers. And for the secondary and tertiary care, you need to go for this PM Jan Arogya Yojana. And that is what is the continuum of care, right? That everybody will get all kind of health facility. If this is a requirement related to primary health care, that will come under the health and wellness center. And if it is related to the secondary or tertiary care, it will come under the PMJ. And what kind of coverage will be there? The cover of rupees 5 lakh per family per year for hospitalization to over 10.74 crore poor and vulnerable families, right? Approximately 50 crore beneficiary that form the bottom 40% of the Indian population. So if you look at the Indian population, then the bottom 40% of the population will get the benefit of this PMJ. That is definitely a very ambitious program, because every family will get basically a cover of rupees 5 lakh per year. Now, PMJ was earlier known as the National Health Protection Scheme, NHPS. That means this program was existing in some other format known as known by a different name. So there is some kind of modification in this, a new name is given, some new provisions are added. It subsumed the then existing Rashtriya Swasthya Bima Yojana. You may remember we talked about Rashtriya Bima Swasthya Yojana 2008. So that means the programs were there, but they were basically meant for limited users at that point of time. Now the names have been changed and some new provisions have been added. These new provisions have given a new, a broader base to these programs, right? So these are the programs which are existing. Then implementation model. Now this is important. Various states are using different models for implementing their own health insurance assurance scheme. The states can implement schemes through assurance trust model, insurance model, or a mix, right? So either it can be an assurance or trust model, or it can be a privately funded insurance model, or it can be a mixed model. The choice will be there with the state government, because in health issue, states do play a very important role, right? It is not the responsibility of the central government also only, it is also the responsibility of the state government. Here I have explained the three models separately: the assurance model, trust model, insurance model, mixed model. I think you got an idea about these three models through our discussion till now. So here we came to an end. Now, I have already consumed plenty of time in explaining the health expenditure pattern and universal health coverage model. So I hope you got an idea. I'm sure that you will have some questions. You may need some kind of clarity. Please note down your questions. Keep them reserved for discussion during the tutorials. And I'll take a short break of 2 minutes, and then I will deliver the second lecture. Both the lectures will be delivered by me. Thank you very much for your patience hearing. So now I'm back, and I hope that the participants are already here, right? So now we have another interesting presentation. The topic is sources of health data in India and emerging issues in health research. Again, we have clubbed here two different things, right? The sources of health data and emerging issues in health research. We'll talk about both the things in this lecture. And as I have already shared in the WhatsApp group, we will have the tutorial at 2:45 p.m. today, because the technical staff for recording and managing everything, they are not available in between the time. So we will start the tutorial at 2:45 and we will continue it till 4:45. Hope all of you find it convenient to join the tutorials also, right? So now we come to the sources of health data. In the previous lecture, basically, you might have seen that everything that we discussed were based on data, basically the macro data, right? And earlier, you might have seen that Dr. Tulika had made a presentation, and that was also based on data, right? So as a student of sociology or social sciences, we are basically exposed to data. We talk about primary data and secondary data. I'm sure that all of you are aware of this, but because some of the participants may be not aware of this. So let me very briefly tell us what is data. So data is known as any relevant information, right? Something which is relevant and useful for you is data for you. And if that is not relevant or useful for me, it will not be data for me, right? So any piece of information could be a data for someone, and it may not become data for someone else. So it is not just to say that if you are finding some numbers written here and there, then that will become data on its own. No, it will depend upon the utility, right? The purpose. So something which may be very insignificant for one person could become a very important data for someone else, right? So this is data. Now there are two levels of or categories of data. One is known as primary data and the second one is known as secondary data, right? What is primary data? When you collect the data yourself, basically, when the researcher himself or herself is collecting the data or generating the data, not just collecting, rather even creating or generating the data, producing the data, then that is generally known as primary data. And when the data which is collected by one individual or one agency is used by someone else, then that is generally identified as secondary data. So that data will become primary data for the person who collected, generated, created it, and will become secondary data for the other person, right? So the same data may become primary for someone and secondary for someone else, right? For example, we all are aware of the census data, right? Government of India every 10 years collect information about the citizens, basically goes for head counting and collecting all the information. That is a census. That is the most rich data, the richest data in India at all India level. That is basically secondary data for all of us, but the agency which is collecting that data, it will be primary data for that particular. And when the researchers collect data on their own, that is primary data for him or her, but it may become secondary data for someone else, right? Primarily, there are there is one issue related to data, and that is the reliability, right? And validity. So generally, we go for testing the reliability and validity of data, and the national governments have to make lots of decisions based on data. We just talked about the Ayushman Bharat scheme, or for that matter, the health insurance model. Everything will depend upon the data. If the government is not having any idea about what percentage of people is living below poverty line, it cannot make provisions for the social security, right? So at every point of time, the government is in need of data. Just like that, the institutions in a university, if an examination is being conducted, then the controller of examination needs to know that how many students basically are appearing in the exam. without having that precise information, it will not make the arrangement right. So data is required at every point of time, even at the family level, household level. How much money is available to the head of the family is basically a kind of data, and where does he or she spend this, that is also need some kind of understanding, planning, but that is also based on data, because how much he spent last month or how much fund was required in the last year kind of thing. So these are all different types of data applicable at different levels. That is why I stated that it will depend upon relevance and utility of that. So that is data. Now, when we are talking about sources of health data, we are talking about that data which is collected by the government and made available at the public domain for general use. There may be private data, right? There may be a data which government doesn't want to leak or doesn't want to provide to the people. For example, there may be several issues related to the Reserve Bank of India, right? Or several other issues related to defense kind of thing. So those are basically the data which are necessary for the government, but that is not provided in the public domain. So any data that is provided in public domain by the government, that is for the larger use. Sometimes people also commercialize this data, right? So at the global level, we can find several agencies which provide data. As of today, we know that all the communication companies basically try to access data. We know that Facebook, Meta, WhatsApp, they are all collecting data. Sometimes we say that they are stealing data about the users, the credit card companies, they are also looking for the data. So the word data is basically used in multiple ways, right? And whenever you talk about data, some kind of quantitative number is generally visible, but data can be qualitative also. In social sciences, we also talk about qualitative data, which is existing in the form of narratives. Here we are talking about the quantifiable data, which is provided by the government, and what are the sources. Because as a researcher or as a student of health science, you may need to understand the data. The previous lecture, we talked about everything on the basis of the data. So hope you understood the larger context in which we are talking about. Now, when we try to understand the health data, then in India, one of the very reliable, very authentic source of data is the National Family Health Survey, right? National Family Health Survey basically started to collect this data in the 1990s, right? Now, this 1990s is very important because at that point of time, see, 2-3 things have happened simultaneously. On the one hand, India and the world was witnessing globalization, privatization, and liberalization. You all may have an idea. At the same time, in the decade of 1990s, there was emergence of a very important concept that is known as human development, the human development paradigm. Before that, basically, we had economic development paradigm and social development paradigm. But this human development paradigm emerged in 1990s as a dominant paradigm, and we must appreciate the contribution made by Amartya Sen and Mahbubul Haq, who basically provided a human development index. Now we need to understand the significance of this. Human development as a concept says that there are 3 core components of development to be ensured at the individual level, right? Economic development talked about economic growth, right? If the per capita income is increasing, if the national income is increasing, then it will have a percolating impact. There will be a trickle down impact. The benefits will come from top to bottom. And this is how economic development will take place. That was the economic growth model or economic development model that is existing as of now also. But Amartya Sen basically stated that there are 3 core components, necessary components, which are necessary for the survival of every individual. What are these 3 components? One is certainly income. And the second one is basically longevity of life, or that is health. And the third one is education, right? Sen stated that health, income, and education, all the 3 components are necessary to develop capability and to enhance capacity, without which basically the individual life goals cannot be settled. So what happened that when we started talking about human development, then health became a very important component. And here we felt at a larger level that we need to have health related data. And under this background, basically, Government of India started a new system, that is National Family Health Survey, to collect the data from the individuals at a grassroots level. So we had the first generation of NFHS data, that is known as a National Family Health Survey first. That was basically conducted in the years 1992, 1993. I have mentioned it in this slide. You can go directly to the National Family Health Survey website, right? And I've given you a picture of this. Here you will find that the NFHS 4 and NFHS 5 data are uploaded directly. And in the left column, you can see the details of the NFHS data 4, 5, 3, 2, and 1. NFHS 1, 1992-93, NFHS 2, 98-99, NFHS 3, 5 and 6, NFHS 4, 15 and 16, and NFHS 5, that is 2019 and 21. So NFHS 5 is very relevant. We are yet to get the comprehensive data in its entirety, but part of that has already been released. So anybody who is basically looking at the health domain in Indian context needs to go through the NFHS data systematically, carefully. A huge information is provided, right? So I hope you got an idea, and this data is freely available, accessible, right? So anybody can access this data, can make use of this data. And now NFHS 5, see, this is one of the front page of the comprehensive report. So it looks like this. And there are several volumes related to this, because as of now, this data is basically getting expanded. Now, basically, we are having the NFHS data for every state also. We are also having the executive summary of the data. So anybody who is interested, who is not interested in taking it in a very comprehensive way, can go for basically the summary of that. Otherwise, the state level data is also available, right? And then the fact sheets are also made available. So this is basically the compilation of the fact sheet, where you will find the data in a summarized form, right? And what is very important, that these NFHS data provide you a detailed understanding of the methodology, the sample size, right? The sample size is very important. Whenever somebody is talking about a survey, then it is very important to understand that how did they collect that data, what was the sample size, which methods or methodology was used for collecting that thing, right? I hope you all have some kind of understanding related to this. But this NFHS data and its website is providing the comprehensive information about the methodology used. So this is NFHS 4, 5. Just like that, you can see 3, 2, 1 also. I'm leaving it for you to explore. Now I come to the next important thing, that is Ministry of Statistics and Program Implementation, Government of India. Now you know that after 1990s, there is a huge revolution in ICT, right? The health policy of 2003 extensively talked about making use of ICT to make the health programs more inclusive. See, no government can make specific schemes for a specific target population without having a comprehensive understanding of the target population. So we know that in India, we have specific social categories like scheduled caste, scheduled tribes, then other backward classes, then women, then basically vulnerable groups in terms of age, like under 5, under 1, or over 60, elderly population, then people with several types of morbidity, sickness. So for that, we need a huge database. And as of now, there is a specific Ministry of Statistics and Program Implementation of Government of India, and this ministry is providing you intensive data, classified, aggregated, disaggregated. So all that you need to do is go to the website of the ministry, scroll the different tabs available over there, and find out which data is available, relevant for you, and you will find plenty of data, right? So anybody who is making use of this data can suggest his comments and can make a presentation on this, that which data basically they have utilized and how that was helpful in achieving the goals of their research, right? In the subsequent part, when we will have the tutorials, I will expect the research scholars, basically who have conducted research recently or who are conducting research, to talk about the kind of data that they have used and what was the source of data. So that way the participants will get to know more about the different types of data, right? But as of now, suffice it would be to say that this Ministry of Statistics and Program Implementation is providing huge comprehensive data, and that is readily available at the website. And see, I have presented another page which is showing you basically the different types of data which are already systematically made available here, right? Ministry of Statistics and Program Implementation. Now here you will find the NSO, that is a National Statistical Office, right? And then again, there is very important and interesting aspect related to the data, that we have the NSSO data, National Sample Survey Organization data, right? Now in India, we have three sets of databases when you talk about the health at a macro level. One is the census data that is conducted every 10 years, that provides lots of demographic information and important information related to life cycle, gender, etc. So that is providing you the denominator, the base, right? But problem is this, that is a decadal data. You will get to know about the people only after 10 years, right? But we all know that the population has its own dynamics, the growth has its own dynamics. So the government cannot keep waiting for 10 years for having access to new data, right? So to meet this need, the government is having another system of collecting data that is known as the National Sample Survey Organization, NSSO data. Now, it is very interesting to know that this NSSO is not only the fulfilling the goal or the target of providing data for the specific time period in between the census, but it also goes much beyond the scope of the census. See, the census has a limited scope because the purpose is huge here. The enumerators go to different households, to every household, and collect information about every individual. So collecting massive information from every individual is a huge task, and sometimes that is not relevant. So what the government has basically planned is to collect specific information from specific people. For example, if you have the need to know the unemployment situation, then this unemployment related situation can be collected from people who are unemployed, right? For that, you don't need to consult every individual over here. So here, some kind of sample survey is also taking place. I hope you understand the difference between a census survey and a sample survey. A census is applicable to the entire population, whereas a sample survey is applicable not to the entire population, but the selected sample, right? So the NFHS, National Family Health Survey, that is a survey based on samples, and this NSSO, this NSSO is also basically based on sample survey, right? So this sample survey has its own limitation, but it has its own benefits, and there are different rounds of NSSO. If you go to the website, you'll find that there are different rounds of NSSO data, and every round of data is relevant because that data is processed in multiple ways, and it is presented in aggregate and disaggregated format for the benefit of the users, right? So this is very important source of data. Then another source of data is Ministry of Health and Family Welfare. We in India at the union government level, we have two ministries dedicated to the health needs of the population. One is basically this Ministry of Health and Family Welfare, and another is the Ministry of Ayush. Ayush we talked about earlier, and we will talk about it at length in tomorrow's lecture also, right? But that Ayush refers to is a basically acronym that refers to Ayurveda, Yoga, Unani, Siddha, Homeopathy, etc. So this Ministry of Health and Family Welfare in itself is having plenty of data. It provides information about most of the programs, right? So if you want to know the way this ministry is contributing, you need to go to the website and find out information about the data. And then we have the National Health System Resource Center. That is again a new system developed, right? And it conducts several types of workshops. It creates, basically, it tries to fill up the gaps which are available in terms of availability of the data. So National Health System Resource Center, you can scroll it, you can find out other types of data available at this level. And then the last thing in this context is the National Health Policy 2017. We just talked about it. We'll talk about it in tomorrow's lecture also. So this policy document is again nothing but basically a kind of argument developed on the basis of data. So you can find several data over here also. And then there are other types of reports also. So far we discussed the data collected by the government. Then there are other agencies which work in collaboration and provide plenty of data. So this is basically India, health of the nation states. You can see that this data is collected by 3 agencies in collaboration. Indian Council of Medical Research, you might have heard of ICMR. ICMR is a very dominant, very important agency in Indian context, taking care of the health needs. So ICMR is collecting plenty of data. Then we have the Public Health Foundation of India, and then we have the Institute for Health Metrics and Evaluation. These 3 agencies came together, collaborated to collect this data. This is also available for open access in the internet, right? So these were the important data. I just want to give you one example. We talked about this slide. Now in this slide at the bottom, you can see that we have mentioned the word source. So this is NHA, that is National Health Accounts estimates for various years. Now see, sometimes we have the data collected directly, and sometimes basically we make some kind of estimate. That is why I have included this slide, that it is technically not possible to collect every data from the ground. Sometimes estimates are also made or developed on the basis of the available data, and economists are basically doing this job in a very fantastic way. So this National Health Accounts is also providing some kind of estimates of the data for the specific year, the specific segment. So some of the data could be like estimate also, right? Then I mentioned here and HSRC, MOH, FW, all the sources we discussed earlier. So by now, I hope you got an idea. This is also a data that we talked about, and health and family welfare statistics in India. These are the sources, right? So by now you got an idea about what type of data is available in the open sources, where you don't need to pay anything. Just go to the website, collect the data and make use of it, and mention the source. Mentioning the source is very important. If you are making use of any data, then without mention of the source, this is basically irrelevant, right? You need to mention the source, the year, the way that data is described, because so that someone can verify the authenticity and validity of that data. That is very important. So by now we have covered the sources of data in India. We discussed some of the important sources of health data in India. And now we come to the second part of this lecture, that is emerging issues in health research in India. See, why did I connect these two topics? Because emerging research is often based on specific information. We could not have thought of talking about issues related to health expenditure had the data not been available. Whatever topics we are talking about today, some of these topics we could not have even imagined to think of in the decade of 1980s, because there was no baseline data available at that point of time. Right. So the issues that we are talking about basically are meaningfully related with the set of data which is available, reliable, authentic data. And that is why data and research go side by side simultaneously. Sometimes research necessitates the need of a specific type of data, and sometimes data help us to identify the specific research gaps. Both the things basically mutually reinforce each other. This journey will take place simultaneously. So after talking about that, let us try to understand. Anybody who is interested in going for research in health related area, then what would be the core issues, right? Or what are the emerging issues? So I've identified the issues at two levels. At one level, I've identified the basic issues, and at the second level, I've identified the emerging challenges, right? So first, we'll discuss the basic issues. When you look at the health-related domain of people, maybe at the individual level, household level, community level, state level, or national level, then you can identify n number of important issues which can be identified as the basic issues. The categorization of basic or emerging is just for a practical utility. It has no other significance, right? You can identify an emerging issue as a basic issue or a basic issue as an emerging issue. There is no claim on that, right? Just for the convenience, I have categorized these things. So what are these? When we talk about health, basically, we need to identify that there are several dimensions of the physical dimension, mental dimension, social dimension, and spiritual dimension. Dr. Swalihin basically yesterday talked about the social dimensions of health. And as of now, we are realizing that the social component of health is very important. During COVID, we all realized that the social dimension of health is very important. And unfortunately, that remains unexplored. The mental dimension of health, that is basically realized by all of us. But unfortunately, at an academic level, we are not having too many studies on mental dimensions of health, and especially from epidemiological perspective. We do have some kind of health studies which address the mental health issues, but primarily those are conducted by the psychologist or maybe the psychiatrist. And there we do not find the epidemiological information. So what basically we need as of now is this, that which segment of the population is having this type of problem? What is happening to gender? What is happening to the socio-economic groups? What is happening to the different classes of population? Because we can identify the mental health problem, but the mental health problems are not same or similar for the different segments of population. So we need to see that at an aggregate level as well as at a disaggregated level. And so that is very important. Then we have the health differences, health inequalities, and disparities. My co-coordinator is talking about what is spiritual health. See, WHO has identified spiritual health also as an emerging dimension of health. See, why do we need health? We all talk about health, physical health, mental health, social health, right? But don't you think this question in itself is very important, that why do we need health? Why do we need good health, basically? And this answer will not depend on the information that you collect on the basis of physical, mental, and social dimensions of health. Because some kind of spiritual understanding, your relationship with the values, the core values of life, that is again very important. Because someone who is not working, who is not much interested in making an improvement in his health, how can you make him or her understand the why this is important to have a good health? And that is basically some kind of connection with some kind of values, or maybe some kind of, for some people, some otherworldly power whatsoever. Even if you don't have a faith on the otherworldly power, forget it. Then you may have some kind of commitment for certain values. So basically, why do we need? The why question ultimately remains unanswered if you have a series of why questions without taking support from spirituality, right? So that is why spiritual health is again very important. Then we have this health rights and governance related issue. Health right. See, when you look at the international covenants on human rights, you'll find that the health rights are the basic human rights. But so far, we have not been looking health as a right issue. In India, we have several fundamental rights. Do we have health right as a fundamental right? The answer could be yes or no. Many people say that the fundamental rights do not talk specifically about the health right, and so in the time to come, it should include health right as a fundamental right. Whereas other people say that the right to life in itself basically includes right to health, because we have right to life as a fundamental right. And when you have right to life, then it will certainly include right to health also. So it is already there in this article. Fine. But as of now, we all agree to this concept that health is a fundamental need. It is a fundamental right of every individual, no matter whether that is mentioned in a specific constitution or not, but this is an entitlement for all of us. And basically, we need to take care of these things. And here, the peer research, basically. Now, the peer research is taking into consideration this right to health of the peer group also, right? So there are n number of concepts. Then basically health inequity. Now, what is this health inequity? We are talking about equality. And along with equality, we also talk about equity and inequity. You may remember Professor Miwako had talked about basically equality, equity, and inclusion in the first lecture, in the first day, right? So I will not get into that discussion. Even that day, I had elaborated these points comprehensively. I hope you can remember that thing, right? So inequity related thing, then a holistic health. Basically, is it sufficient to look at the health issues in isolation only? Somebody is taking, how can we take care of the mental health without taking care of the physical health? Technically, that is not possible, right? So there is an increasing understanding that we need to look at health in a holistic way, right? This holistic is again a very comprehensive word. We can have 1, 2, 3, 4, 5 lectures just to explore the concept of holistic health. So that is about health. Then comes the illness. Now, illness, what is the difference between illness and sickness? Basically, we elaborated in the first lecture also during the tutorials, but illness narratives are very important. Now, the medical sciences as well as the social sciences are increasingly finding out that the illness narratives are very important, because the description of the illness is not presented in the same way by all affected people, may not be represented in the same language, right? So the narrative is important. One of the important causes of causation of chronic disease is basically the failure of the healthcare provider to understand the illness narrative presented by the patients. Very often people go to the doctor, they explain the problem, and the doctors, because of some or the other problems, could not understand. And some or the other part related to the description of that problem is remaining missing. And so, as of now, illness narrative has become a very important component of this healthcare, right? And along with that, there is a narrative medicine also, right? An important component of medicine is emerging as narrative medicine, right? So then we come to the disease. Of course, we have seen communicable, non-communicable, chronic, and acute. disease and simultaneously different types of treatment. So all these dimensions are basically the core issues of research or the basic issues of research. Time will tell us that when shall we achieve a complete control over these things, because we develop control over certain diseases, for that matter, eradication of smallpox, right? We successfully achieved that. To some extent, we also achieved the goal of eradication of polio. But where do we exist in terms of eradication of malaria? We are nowhere closer to even that eradication of malaria or eradication of tuberculosis. I'm associated with ICMR in one of the committees to take care of the kind of research which is going on in the tuberculosis sort of thing. And we get to know that different pockets, different segments, different geographies in India are basically witnessing the problems caused because of tuberculosis at different levels. We have the multi-drug resistant types of disease. So it is multi-drug resistant tuberculosis, multi-drug resistant malaria. That means the disease is changing its form. The vector which is causing the disease is changing its form. It is becoming drug resistant. Now the problem is basically increasing several times when you have a drug resistant vector. Then we have different types of medicine, different systems of medicine, and within that we have different kind of thrust areas. Sometimes we talk about medical pluralism. In India, we have existence of different systems of medicine, the Western medicine, ethnic medicine, social medicine, then different systems of treatment like allopathic, Ayurvedic, homeopathic, Unani, folk. Then the tribal people have the ethnic medicine kind of thing or the tribal medicine kind of thing. Then we have different systems to provide this medicine. We have the government sector, private sector, then we have the NGOs or the trust sector. All these sectors have different philosophy, and we need to explore those things, to what extent these are basically meeting the need of achieving the goal of health for all. Then we have different indicators, basically fertility, fecundity, morbidity, mortality, then different levels of mortality, infant mortality, neonatal mortality, under 5 mortality. All these are basically coming under the basic issues. Then we have the social determinants of health: food, nutrition, water, sanitation, housing, dress, environment, education, income, work, inclusiveness, participation. These are all the different social determinants of health, and each of them play a very important role. Occupation, work inclusiveness. These are all presenting different types of challenges to the health needs of the people. See, after globalization, liberalization, and privatization, the service sector expanded massively. Then now we have, we developed a specific service sector, right, known as the call center. Now people are working in the call center day and night. Now people are working in the night shift continuously. They are having a different set of problems, right? Because their biological cycle is getting affected because of that. So they are witnessing different types of problems. Then we are having the service sector like banking, insurance, where people are constantly sitting over a computer. They are having another type of problem, which is not only remaining confined to the physical domain, but that is also getting translated into the mental domain. So then we come to another set of things, the processes: medicalization, demedicalization, corporatization, privatization. Yesterday, one of the participants, Tazibanis, talked about medicalization, over-medicalization, and under-medicalization. Now, all these things are happening simultaneously, right? One community in one specific area may be exposed to over-medicalization, and in another area may be exposed to under-medicalization. What kind of dynamics is emerging because of that? We need to see these things at a micro level. The macro level data will not suffice the purpose here, because we cannot collect that data at a macro level. So now you can understand the need of this health research, because on the one side we have the macro level data, but it is beyond the scope of the macro level data to provide a specific information on the micro level things happening at the household level, family level, or community level. Then we have witnessed increasing occupations right? There is a massive industrialization, massive globalization, new sectors are coming into existence. And because of these things, new challenges related to occupation or occupational health are emerging, right? So the occupational health issues are again very important. We need to address those occupational health related things. These are some of the core issues that I have identified as basic issues. And then comes in the last part of this lecture, the emerging issues in health research. Now, these are emerging. We do not have a comprehensive understanding of the topic itself because these are evolving phenomena, right? And we need the contribution of the social scientists even to understand the phenomenon. All of you might have heard of surrogacy. Now, what is surrogacy? Basically, sometimes that is also known as a hired womb, right? That means the parents who are not able to conceive due to some of the biological reasons, they may go and hire some other person, and that is known as the hiring the womb, basically for the growth of the fetus over there, right? That is known as the practices related to surrogacy. Now, does it engage lots of health related issues? The answer is yes. Although the fetus is genetically connected with the biological parents, but that fetus basically nurtures, grows in the womb of the hard womb. So the health of the women who is basically nurturing that womb, that fetus in her womb, that becomes an important consideration. Now, how that is affecting the health of the child which is growing inside the womb of the mother, and how that is affecting the health of the mother. That is an important sociological issue. That is important social concern. Are we aware of that? Perhaps we are not aware of that, right? What kind of intervention is required? There are so many dimensions related to this. And what are the mental health related conditions due to this, right? So I just picked up one example. Public health and lifestyle disease. Diabetes has become different levels of diabetes. It has become a lifestyle kind of disease, and some of these are basically recoverable, and some of these are non-recoverable. So what kind of combination diabetes is creating with the other existing disease, comorbidities? Now, these are basically least explored things. I think people from social sciences need to come forward, carry out detailed ethnographic studies on these, because the description in itself is not known. Now, earlier I stated that there is a lack of illness narrative, right? So as of today, we cannot completely depend upon the narratives presented by the patients. We need a scientific account of those narratives. And a scientific account of those narratives will come only when a researcher will take up the challenge and record those narratives and get them verified at multiple periods of time. So lifestyle diseases are basically increasing. Everybody is understanding that the cardiothoracic, heart attacks, brain strokes, right? These after COVID, these have increased also intensively, right? As per the records presented by people, word to mouth kind of category. They may not be they are not much documented as of now, but on the basis of our observation, we can say that these cardiac arrest or brain stroke kind of problems are increasing, right? That we can see in our day-to-day life, in our community life. Then there are other issues basically related to intervention of machine and technology with the body and mind. Every day we are having a new kind of technology, and this new type of technology is intervening with the body in a new way. Cloning, you might have heard of cloning, right? Then plastic surgery, right? You might have heard of Michael Jackson, right? And then in your community, you may be witnessing people who want to look younger, or maybe people who have some kind of a specific injury, or maybe people who want to improve any special appearance because of some or other intervention that is often basically performed by plastic surgery. Then sex change. This sex change is a huge core emerging issue. We don't know what may happen after 10 years or 20 years. What percentage of people may think of going for sex change? Then embodiment, the way the body is responding to kind of the interventions. Then the massive medicalization. Then transplant surgery. We are seeing every day that some people are getting kidney transplantation or say other important organs of the body kind of thing, right? So what kind of complications these are going to create? Artificial organs, ventilator assistance, renal dialysis, all these typical medical problems are having a specific socio-economic, cultural, and sometimes even politico-religious concerns related to that. So we need to understand these things. Then I just talked about the surrogate mother, hard womb. Now, and different type of relationship, the live-in relationship is becoming. Now, this is considered a parallel to marriage. But what may happen to the health-related issues, especially the mental health-related issues of the couples who are living in these relations? Then tremendous growth of medical profession and stratification and hierarchy within it. Every day we are witnessing there is a growth of rise of one or the other kind of super specialization. That the growth of the super specialization is affecting the medical discourses themselves. Who will try to understand those things? Then health governance, entitlement, rights, disability, impairment issues. Then differentiation between medical care and health care. Now, one important thing that I'm personally much interested in, I've written papers on this, that often we consider medical health, medical care and health care as the same thing. These are not. Medical care is a different concept and health care is a different concept. Healthcare is a basically holistic concept, comprehensive concept. It takes into consideration several dimensions related to health. Medical intervention is only one specific dimension, although it is huge in itself. It is a complete world in itself, but definitely the healthcare is not just defined by medical care. Medical care in itself is taking into consideration one specific dimension within the healthcare, because we need to talk about food also. We need to talk about nutrition also. We need to talk about sanitation also. Sometimes that is identified as a public health concept, but that is a healthcare. The care component has been discussed the least. Who will provide the care? As of now, the family is basically the supporting agency. But the way the internal dynamics of the families are changing. Now, the biggest challenge in elderly health is the lack of healthcare provider, right? So that is actually getting affected because of the changing composition of the family and the kind of occupational mobility and social mobility and physical mobility that we are witnessing. So how these things will address or will affect the health of the elderly people, that is something that time will tell us. Then corporatization and privatization of medical and healthcare. I talked about this topic in the previous lecture. Then mental, spiritual, social dimensions of health, health inequalities, inequities, and then comes the human development and sustainable development aspect. See, human development is not possible without focusing much on the health issues. Longevity of life in itself will not serve the purpose unless we take into consideration the daily, something that we discussed earlier, right? That is the disability adjusted life years. If life expectancy is increased and that is not free from disability adjustment life years, then this kind of life expectancy is basically proving to be a burden in some of the contexts, not in all the contexts, but in some of the contexts. So simultaneously, we need to address those issues. And so human development is a very important concept here, and sustainable development. Sustainability is the core issue. We have the sustainable development goals. Sustainability is a core issue. We cannot basically make this planet Earth safe for our living without achieving the goals of sustainable development. So the all health issues are primarily related to the concept of sustainable health also. So all these things are there. I hope you got an idea, a comprehensive idea about the emerging health issues. I will suggest the participants here that if you are aware of some other concepts which are also seeking the attention of the social scientists or the society at large, you can talk about those things in the tutorial part. Yes, we have palliative care, we have gerontological issues, we have several other issues, but I think you might be aware of some or the other aspects related to the fields that we have discussed just now. With these words, I'm coming to the end of this lecture, right? It will not be technically possible for us to address the questions because we are not left with time. But yes, we know that we have the specific tutorial session for this. There are many participants who have written thank you, thank you, thank you. So thank you very much to all the participants who have written thank you. I hope they have enjoyed the lecture, and I will enjoy this lecture only after listening your comments, your questions, and if we will be in a position to answer those comments. Dr. Swalihin, the co-coordinator of this course, will remain available with me to answer your queries and to make his own observations and comments in that segment of the lecture. Thank you. Thank you very much. Thank you very much.